And this is the case that I'm going to present. It's a hip with bony ankylosis, spawned in a young 26-year-old chap. Do we put it to the panel, or
yes? Let's put it to the panel.
It?
So you want to tell us what?
I'll look at the whole spine, starting from the neck all the way down. There is a possibility of having a pseudoarthrosis somewhere in the spine, in a stiff spine, and I would like to have a lateral view of the spine as well to see how the lumbar lordosis is. These patients can't sit if they, I mean, it's very difficult for them to sit if they are stiff in extension. So it's not going to make any difference in the sitting, standing X-rays. All I want to see is the lateral view.
Can you show us the AP X-ray of the pelvis again?
Yeah.
Right, so sometimes the pelvis is tilted posteriorly. It doesn't look like it's tilted posteriorly in this one.
Undeformed bilateral ankylosis, so relatively easy to do. Only thing is we have to be sure that the ankylosis hasn't gone up to the cervical spine, because in which case you may need to have a special fiber optic intubation ability with your anesthetist.
Intubation, difficult intubation because of the neck movement. Yeah, excellent point.
And also the TM joint. They can't open their mouth often because of the TM joint.
So restrictive lung disease.
Restrictive lung disease because their ribs don't move, is it, or because something else? Yeah.
Does it change your surgical approach if you're a posterior approach man? Would you ever think of changing your approach in these kind of patients?
No, we go by double approach as described by Dr. Ranawat. We go by posterior approach, expose the posterior flap, then go in the front, expose the anterior flap, and you can cut the neck from the base of the neck from front and back.
Lateral position behind the gluteus.
Lateral position always,
and in front of gluteus.
The only problem is if both the hips are fixed in a wrong position, like abduction,
the positioning
then it may be difficult to give a lateral position.
So that's one issue, but I think if there's a real first-class indication for a direct anterior approach, it's ankylosed hip. I don't have to bother about positioning. My anesthetist is most comfortable with a stiff neck, and I can use
So it's safer from an anesthetic point of view. What if they've got a flexion contracture?
Yeah, that's right. Most of them have big flexion contractures. So how do you position, and how do you do your anterior approach with their hip flexed?
So that is an issue, and then what you can actually do is what he said. You can start with the lateral incision. And it's not going to be the ideal direct anterior approach, but we have done that in the posterior approach, like he said, divide the neck in external rotation and do it. But in a severe flexion, it can be a problem.
Patient's position lateral, not supine.
Yeah, so in a very severe flexion deformity, it is a challenge. Sometimes we have done in not very severe deformity, but we had challenge closing the wound. It was such a bad flexion deformity, so we had to close the wound in flexion and leave it and gradually give traction to straighten it out. So it can be very bad, but positioning them in any other position if they are abducted is very difficult.
Yeah. Okay.
In some of the cases, the dual approach is very useful, especially the flexion abduction and external rotation. There, the posterior approach itself may be very difficult.
Okay, yeah.
So if you have dual approach, you can make a cut, the neck cut from the anterior approach, and then you can go on with your posterior approach.
Okay, and so is this the same patient?
This is not the same patient, but we tend to get that patient's X-rays are there. But so we get sitting and standing X-rays for most of these patients. As Dr. Malhotra mentioned, if it's an ankylosed hip, it's not really going to change, and you won't be able to get him seated properly.
No.
We haven't started doing the flex seated X-rays yet.
Thank you.
What we found is there is about 15% incidence of spinopelvic abnormalities of patients in our population who haven't had any spinal instrumentation. So we do need to watch
15 or 50?
15, 1-5.
Yeah.
So the neck osteotomy, I think most of the panel agrees that it has to be an in situ osteotomy for it. What are the landmarks that you use if you're using a non-navigated technology or non-robotic technology? What are your landmarks for reaming?
That's what I was going to say. What are the landmarks for the neck osteotomy first, and then the landmarks for reaming the acetabulum? How do you know where to put your cup?
You just follow the neck.
Okay, so let's say, so the neck cut you think will be easy. You can see the gluteus medius coming into the trochanter. You might be able to palpate the lesser trochanter. Exactly. You've got an anterior-posterior exposure. You've got all the way around it. You cut the neck. Right. Dislocate the hip. You push the femur forward.
You make a little dowel of the neck.
Yeah, make a little dowel, so you take a piece out.
Yes.
And then you ream into the head.
Yeah.
So how do you know when you've got to the floor? How do you know when to stop reaming?
I mean, you can see the fovea.
The
and,
fovea.
Right, that
So
usually
you
will
might
still be
see
there.
some fat, there'll be preserved some fat there,
Yeah.
yeah. Do you, and, yeah,
The best that I find is just make a drill hole in the
Drill hole.
center
Yeah.
and
Yeah.
measure.
Yeah.
So if it is, to leave it when you are 1 centimeter.
yeah, so I do the same thing, get a small drill, 2.5 millimeter drill it through to the floor until you know where it is, then you know how much bone you've got, front, back, middle.
I think you said it, but just to or you did say it, but just to emphasize to people, there's always still fat in the fovea,
Yeah,
right? So when you see that fat in the fovea, that's a good landmark.
Or we could take an image intensifier and to check whether we right up to the teardrop or the floor of the acetabulum.
Okay.
And these bones are so osteoporotic sometimes that you
Yes.
have to be very careful in reaming.
Yes.
Over reaming is very easy.
easy to over-ream, so you'd under-ream by, if you normally under-ream line to line or -1, you might go -2 or -3 and be very gentle with the reaming.
Yeah. So this is a different patient. As you can see, the AP pelvis now is nearly an outlet view,
Yeah.
telling us that this is a flat back
Posterior
deformity.
Yeah.
Angst-Pond, the angle doesn't change. So in these stuck sitting position, we have reduced the anteversion, and this is the post-op X-ray from the patient that we talked about. So I think David is on this paper. This is the award-winning paper for the hip spine classification by Vigdorchik et al. And they have given us a nice guideline whether or not we should change our anteversion depending on whether they are stuck sitting or standing. So I think that was probably the message from this.
So can I ask Dave?